our first guest. And that is, I just want you to know, I want to say thank you for being with us. And when Beth and I were talking about having people join us, you're at the top of the list.
Well, I'm really honored, and I really am very grateful that you chose me to sort of be the guinea pig and sort of the first person to join you guys in these. I know that the message you're trying to bring out to everybody is very important, and I appreciate the opportunity to join you this morning.
We're so excited you're with us.
Oh, God.
Thank you.
Yeah, so I think the reason you came to mind, one, is because we love you. Everybody loves you. And that's really an anomaly, especially in behavioral health. And as long as you've been around, you would think that there would be some folks who would think, not. But everybody loves you, Tom. And that's because I believe it's because you have always put the needs of those we're serving first.
Well, thank you. I appreciate that. We all have our, I guess we all have our own journey, and, that having lived that life experience that people go through, as I've shared with you, I had my own experience. And so that's the truest sense of empathy. This is all I've ever done. I didn't, sell tires 2 years ago. So I appreciate you saying that. You probably haven't met everybody yet, but I'm sure there are people. But I feel good about what I've been able to do. I can sleep at night. Based on all the different things that I've done, whether it be clinical, whether it be intake, whether it be interfacing with families, even in a variety of different leadership roles or leadership support roles. So it's been a wonderful journey,
culminating in this awesome endeavor that you started. Are we a year in now?
Officially we launched November of 2018.
Yep.
We really didn't hit our stride until probably about January, because we launched right around Thanksgiving, and that's not usually a very wise idea, but that just happened to be the timing of how everything kind of fell into place. So if you look at that, it's been about a year and a half. We're grateful for being able to fulfill need. And so that's, we've been focused on, what is the clinical delivery and how can we do things differently compared to a lot of other programs. And I think that's paid dividends. And there was obviously a great need in the community. And, that's why we're here is to fulfill need. And so we've been fortunate to be, I think, pretty successful in being able to serve people, because there was a huge void in the market. And I like the concept of being able to kind of bring it out into the community and make it available to people. And otherwise, people are having to drive into town, or, you've worked at the hospitals and what kind of commute it can be and how that's a barrier for people. And so by bringing this out to the client, as opposed to the client to the facility, I think that positions us for success. So we feel good about it. And, we're a year and a half in, and we've got a PHP, we have an IOP, we're working with adolescents, we're working with adults, we have a second site, we have outpatient services. So we have a broad spectrum of stuff that we've been able to bring to the market in a relatively short period of time. So we feel pretty good about that.
Yeah, and we love it, and we felt that void in the field too. And what you've always said since the beginning is that you want to serve a full spectrum of behavioral health. Is that accurate?
It is, and the whole vision for family behavioral health is really about identifying needs. So right now it's PHP and IOP, right? And establishing those services in the community so that it's accessible, it's feasible, you can integrate with local providers, really get to know the community, build confidence and trust. But it's also about evaluating what are other needs that are in the community. So PHP and IOP is only one facet of what the vision is. The vision is to really evaluate what are the overall needs of the community and how can we serve those needs. And that's going to take a variety of different forms, not just PHP and IOP.
Right. So more to come. That sounds
more to come. Yeah. In fact, before I got on this call, I was working on the strategic plan, and that is sort of outlining kind of what we're looking at for the next year. And then, of course, there is the vision, as I've mentioned, of looking at what are some other services that we can offer, whether that be clinical or non-clinical. So we're actually looking at all different types of different services.
awesome.
I'm intrigued.
So, for example, schools are sort of a community outlet, right? A lot of families go to schools, obviously the students, the teachers. And why aren't schools really community centers, right? A lot of students get their food from there. Some schools have partnerships with dentistry or eyeglasses. A whole host of different services are offered at the school. We need to examine how we can bring behavioral health services to the school, because the school focuses on academics, and we all know that school is an important experience in psychosocial development. So how can we support that? So there's all different kinds of different things that we need to look at in terms of how we integrate behavioral health into the community.
Man, that's so innovative. What we love about what you do at Pyramid is that, like what we do at Hope, we've very intentionally de-siloed behavioral health, and we've talked about this before, so that it's all about healing, recovery, all under one umbrella. Behavioral health. That's what you do. That's what we do in a recovery support way. You do it in a clinical way. Well, now you're talking about de-siloing within the community, which is that is incredible.
Yeah, part of our mission is not only to deliver exceptional clinical care and change the experience of what behavioral health is, but it's really also about community integration. Integration looks like a variety of different kind of things. Now, certainly that means that you build confidence and trust in the clinical community in terms of what you're providing. But I think that we have a responsibility to provide education to the community and destigmatize mental health.
Yes.
We've been, that's why we've done some of the films, for example. We showed the film Angst, we've showed the film we've shown Screenagers, we've shown the movie Resilience. And so it's a way to provide community outreach, to raise awareness, to start that conversation around the kitchen table, right? And really make this a part of the discussion, because really, if you look at behavioral health conditions, they're just as prominent and prevalent as things that we talk about without any sense of stigma, whether it be diabetes, whether it be hypertension, whether we talk about cancer, all of those kind of things. We talk about our family and our friends and in our churches or other community social gatherings, and we need to be able to do the same thing when it comes to behavioral health. And that's sort of the key term, is health.
That's right.
Health is just as important as our diet, our exercise, our sleep, how we maintain our sense of well-being and stress reduction and all those kind of things. That's all part of health. So, and I think ultimately that's where medicine is moving. I mean, that's what was sort of started by the ACA, was making the primary care office really the health home, that they look at all domains of the individual. So.
Right. And when it becomes mainstream like that, it takes all the shame and stigma out of it. So I really think you're onto something, and just the way you talk about it as a health issue. This is not a moral issue. This is not a weakness issue. And it's not an issue any of us need to be ashamed of, because you know what? We are all affected by behavioral health issues. We do not know. Nobody knows anybody that's not affected by this, especially in these COVID times.
Especially.
I think we play a role too in that. I think even unknowingly sometimes contributing to stigma or this looking like a moral issue by way of the language that we use, which is one of the reasons I think we try to be so intentional about the language that we use when we talk about folks, even when we talk about a reoccurrence of symptoms, or as opposed to, or not referring to somebody as an addict, or it's really being very mindful of what is our language. And
I agree with you more.
And that is something that Beth, you have always been so on the forefront of, and making sure that's something that we emphasize first to our counselors, the folks that are working directly with our residents or our clients, and as delicately as we can, trying to share that with our partners in the community, treatment centers, other colleagues. And it can be a touchy thing to approach, because we don't want to seem righteous or that we're correcting anybody or elitist or better than in any way. But we would like to share, at the same time, we'd like to share how we view things so that the industry as a whole can come along and be thought of and held in a different regard than it is. I think lots of things go on in the behavioral health field with providers that are shameful, and that needs to be brought along. I think.
Well, I agree with you totally. I mean, language matters. And, the language that you use kind of sets the tone for the individual, the receiver, right? I mean, it's about creating a message that's consumable by the person receiving the message, right? And that's why I have not used the term mental illness. We call things behavioral health issues, or we call them behavioral health conditions. And, if you look on our website or if you look at any of our collaterals, that kind of language creates stigma, and we're trying to do the opposite of reducing stigma and not putting people on the defensive, and helping people to realize that these are just as common everyday things as I've mentioned, diabetes or hypertension.
Yeah, and it's coming from a place of strength, right? Not starting with the problem, the illness, the sickness. It's coming at it from we can provide a pathway to help you find health. So I love that your language reflects that, and we're kindred spirits in that. And I think we've had a really synchronistic working relationship throughout too. And I'd love for you all, maybe we could do a little collaborative work right now for this coffee talk about what works well, because you two are the ones really in Atlanta that are working directly with each other, with our teams there. What works well in the residential PHP, IOP configuration? What is a growing edge goal, if there is one? But I think we've had a number of success stories working together, even in the short time that we have been in this capacity. So I was wondering if y'all could speak to that.
Well, I think the world is our oyster, right? I mean, I think that that having the supportive living environment that you provide, one that is delivered by people that actually have clinical supervision, and there is, I know that Hope Recovery Resources is not a treatment provider, but it encapsulates the client with support services, which are essential to being a supportive living environment. And that's very beneficial to our clients. And it's all based on what that individual's need is. So, typically we'll have a client that needs an environment like that, whether it be a young adult who needs some support, maybe the family needs respite. The client might need to start the process of individuation, because if we want them to be independent adults, they need to assume some level of responsibility for their own well-being, whether that be medications, adhering to a schedule, all those different kinds of things that you and us offer. They might need that psychosocial experience for that continued development from a psychosocial perspective. So there's a whole host of different reasons why it's really effective. For us, we also see as an additional or a ancillary level of care. So we offer PHP and IOP, and our clients either will start off in PHP and Hope Recovery Resources, and through our collaborative efforts, we'll be able to wrap services around the client to position them the best for success, and really help the client to reduce any distractions, and develop a consistent routine. That always helps by having some consistency in their routine. And through our collaboration, I mean, when if a client is struggling, we have established rapport for us to be able to discuss that client and how can we intervene early. And that's the whole idea here, is to intervene as early as possible on the condition that the client is experiencing, right? If we have a client, and this has happened before, we've had a client with you that, didn't come for PHP one day. So, we reached right out, let you know, and somebody intervened right away and, checked in with the client, and the client came. And so otherwise, left to their own devices, they may not have been able to benefit fully from the program, right? And so it's a really very beneficial. So we see it as not only a supportive living environment on the front end of treatment, but also as the potential for clients to receive supportive living if they're struggling in PHP or IOP, right? That, let's say if they started off just doing PHP, but they're having problems adhering to the schedule here, or attending on time, or attending frequently, or the home environment is toxic, or they need other measures of structure, then we have Hope Home, Hope Recovery Resources to be able to refer to help provide that structure. And that's really essential to, again, positioning the client for success.
Yeah.
And it's okay to say Hope Home still.
Okay.
Yeah, it's okay. I just want to say that Hope Homes hasn't gone anywhere. It's just become part of something bigger.
Sure.
So it is one of the resources. That's Hope Recovery Resources. And so it's okay.
Okay.
Yeah, but that's a beautiful description of the collaboration. And by the same token, that our team can give you a heads up coming into the morning if there's been a difficult night, if there's something going on with the family, whatever it is, that communication is fluid. And we really feel like we're a part of the same team, even though we're two distinct organizations. And I think it bears saying for the record, there is no connection beyond an intentional collaboration on behalf of our clients and their families, that we're very separate organizations who have made a decision to collaborate due to our shared values, approaches to services, etc.
100% agree with you on that. And I think that is actually a distinct advantage, because that, Kira, you talked about some of the business practices of some providers. And I think that by having services as supportive living services with other providers, that they have that, sometimes that can create a hidden agenda, right? And we've had the experience where clients have gone to other providers that may have had a broad spectrum of services, including supportive living environment. And sometimes the agenda to get that client to enroll is not based on clinical need, but it may be revenue, or it may be some other hidden agenda that is not strictly focused on what the client's needs are, what the client needs. And let me just say that, I don't have like evidence of that, but that's the perception that can create if, somebody goes somewhere and they're recommended for residential. And I think that that's another problem, is that there's this disconnect of the semantics of what is truly residential. How are we using that term, and how is that causing confusion when you talk about levels of care? Indeed, clients reside there, but that doesn't make it a residential program, right? That is a supportive living environment, and we have the PHP, and residential is a different level of care, different setup clinically to work with the client, different sets of needs in a residential compared to how we're collaborating, working together.
Yeah, so it's helpful for families who wouldn't think about this in a crisis to hear what you're saying, and to when we're looking for services, what is that facility licensed to do? If they are a clinical treatment center, are they licensed as a IOP or partial hospitalization PHP? Are they licensed as residential treatment? So you'll probably know if you're licensed as residential treatment, because that's a standalone facility by and large, right? That
contained environment.
Right, a contained environment. So, but you're 100% correct. I see it a lot online in materials that clinical environments will say they're residential because they have that agreement, partnership, whatever it is, with a sober living, but it's not a residential setting at all. It's a working arrangement with agendas that might not be fully transparent.
Right.
And I think that my understanding is the way that the model came about is for some fluidity, right? That I mean, I got a call the other day from a treatment center, a discharge planner, that said we're looking for an IOP PHP with housing. And it's a way of providing a level of care for someone that is kind of in between. And I think that can be very positive, which is one of the reasons that we like to collaborate, Tom, for the reasons that you said. The difficulty, I think, or the trouble comes when there's a financial connection between two programs, is that it limits choice.
Mm-hmm.
It limits choice for the client, which is what is not in the best interest of the client, right? Because automatically, if you're in this PHP IOP, you're in this recovery residence, or if you're in this recovery residence, you have to be in the PHP IOP. And there's some muddying of waters, right? That and it can look as though that supportive living is very inexpensive. And so it's attractive for those reasons. It's proximity, it's affordable, and it's not ethical because insurance isn't supposed to be paying for that residential, like Beth, what you're saying. That's not what is being covered or what they're licensed to do. So, and it limits choice, which I think is the biggest issue, because different recovery residences serve different purposes and populations, and there's nothing wrong with that. But does this meet the need? Maybe not.
Well, and I think that's one of the brilliant things that, to you, Beth, to your credit, you helped create the tiered system that provides clarity of how the supportive living environment differentiates among them, whether it be peer, a level 1 or a level 3, or what's a level 4, and how can you really identify and have clarity about how these all are different. And what Hope Homes does as a part of Hope Recovery Resources is, both of you are licensed clinicians, and you didn't sell stocks 2 years ago or a year ago, and now you're setting up a recovery residence because now you're sober. I appreciate the desire of the individual to contribute and give back to the community. 100% respect that, but we have to make sure that we're delivering what we say we're delivering, and for the consumer to have some differentiation among all those different levels of supportive living environments. And that's why we chose to work with you guys. Not only, I've known you guys each for 20 years
at least.
And so at least is right. So, we've grown up together, right? We're getting older together. So
you are, maybe I'm not. No.
And we have a philosophical alignment. I think that we're all focused very much on the client and their needs. So that philosophy is very important. And I think creating an environment that is supportive of the client from having that clinical perspective is really essential. I mean, it's 2 licensed social workers, not the stock trader that's been sober for a year or 2, right? That's still in early recovery themselves. So, we really appreciate that about you guys. And that's really the main reason why we want to refer specifically to Hope Homes is because of the level of trust, what you bring to the table in terms of creating an environment that's very supportive for the client.
For a more complex client too. And that's why we appreciate working with you, that you are not one aspect of behavioral health. You really consider the whole whole enchilada, the whole spectrum of behavioral health issues is what you've always strived to serve, and we appreciate that. We needed it.
We serve a population that's truly co-occurring.
Mm-hmm.
We're strictly,
Yeah.
I'm sorry, my computer just like made you disappear. There are people with us that don't have any substance history of using substances inappropriately. And like you said, the market was really, there was a gap and there was a void. So with the spectrum of people that we work with, we were really happy when you opened your doors.
And, you know, we're pioneers. All of us are pioneers, right? I mean, when it comes to outpatient behavioral health services, aside from the addiction sector of behavioral health, there's been very few resources by history in this community. And so, and I don't know of any other supportive living environment that serves those with behavioral health conditions besides addiction or substance abuse or eating disorders for that matter, right? I mean, there's no freestanding. And so, you know, you are pioneers. And when it came to Pyramid, there were really no freestanding programs dedicated to serving those with behavioral health conditions such as mood and anxiety disorders. So, you know, we're forging this path. We're pathfinders. There's very few models, so we're having to use our years of experience to be able to deliver something of quality to people in need.
Tom, can you remind me? So I think one of the things that makes you different too is there was this void for behavioral health conditions, but also age-wise, there was very little. And we don't work with people younger than 18, but you do, right?
We do, yeah. We work with adolescents 13 and up, and that's been a huge void. And it's really difficult for families to access services because most of them were concentrated down around the city or the perimeter, you know, and we're up in Johns Creek, 15 miles north of 285. And in normal times outside of the pandemic, it was a barrier. You know, people would wait for their condition to get worse. And so, especially with adolescents. And, you know, if you look at the research data, if you don't address those conditions when they're adolescents, it'll carry into adulthood and affect their ability to be, you know, functioning adults contributing to society. And so, you know, it was the opportunity to change the trajectory of people's lives. And so we do that as adults, certainly, but, you know, when it comes to adolescence, that's a lifetime of wellness that you can help the client realize. And that's very rewarding, very rewarding.
So when are you coming to the West Side?
The West Side, well, you know, that is in the plan, actually.
Okay.
That I was talking about, that strategic plan. So
Yeah.
Site 1, and now I got to get Site 2 reopened. In fact, we are scheduled for that.
Good.
And then as long as things are looking good for the Johns Creek location, we get Sandy Springs up and running again and you know, going pretty consistently, then by the end of our fiscal year, which is July 1 to June 31, we'll have our site set on Site 3, where that exactly is going to be is to be determined. But we have some locations in mind, 3 different locations geographically, but I'm not sure where that's going to be yet. So, you know.
I'd love to talk to you about that. And
Pardon me?
I'd love to talk to you about that, and I can put my request in.
Oh, that's awesome, Tom. One of the things I was wondering is I know you believe in access to care anytime in the spectrum. So it might be that you're the first point of entry to care, and often I think you are. And other times you and us too are more of a step down at once stabilized. So what are the percentages of that for you? Have you noticed any change in that? Can you speak to that?
So for us, I would say early intervention, I would say it's probably about 50-50.
Yeah.
And I think we still have to work on the message in the market, because we've only been around for a year and a half, right? So part of our message is that we have to intervene earlier, just like we do when it comes to heart disease, right? We don't wait for the heart attack to get treatment for a cardiac condition. So I think that is an area we need to continue to strive to work and improve in carrying the message about early intervention. I think that we had, so it's kind of swung. So when we first opened, we were probably more early intervention and we had some step down. As we've been in the marketplace for longer, we've had an uptick in more step down than early intervention. Maybe that's just because the volume is higher than when we first started, of course. But I think that the early intervention is really important to not have clients needing higher levels of care like residential or inpatient, that we need to intervene on the disease process earlier to avoid the need for higher levels of care. I also think that there needs to be more education for the clinical community on what that continuum of care looks like.
Yeah.
I think that sometimes they lack that understanding, don't have clarity of what is a PHP, what's an IOP, how are they different, at what point do you make the referral. I think that's an area that we also need to work on, not only in terms of message of early intervention, but also in defining what those levels of care are.
That's something Beth and I have been working on for quite some time is how do we plant those seeds and how do we start providing that education for the outpatient clinician, for therapists, for families. Earlier you were mentioning, level 1 or level 3, and that makes sense to us because we're, that's our language every day. But
right.
The layperson, they have no idea what a level 1, they would have never had exposure to that. And so, we've talked about things from continuing ed to a community event of some kind. Of course, it's complicated now, with COVID. But maybe one day we can talk about that with you and maybe collaborate on something like that to bring that information to the professional community, but also to the greater community.
I would love that. I would love the opportunity to be able to do that with you. I think that would be really helpful and beneficial. In fact, if you guys recall, we actually had been doing some of that a few years ago. Remember the big event we did together? In fact, Beth, you presented at at one of those, talking about the different levels of care within just the supportive living environment, right? And helping the professional community to have more clarity about that.
Right.
As I've worked with families, the best way that I've found to be able to help provide an understanding of what the different levels of care is just using examples that they are familiar with. For example, I and my staff is probably very tired of hearing about this, but I always use the sprained ankle scenario, right? when it comes to the continuum. And so you draw it out on a board, and if you step on it, step in a hole in your yard and you sprain your ankle, you're on this end of the continuum, right? You're in outpatient counseling, or you see the primary care doctor. You're there for an hour, you go home, just like in counseling, right? So that's one end of the spectrum on a low intensity of services. But if you broke your ankle, you're on this end, right? You're at the emergency room, you're getting triage, you're getting diagnostics, right? And if you have a broken ankle, maybe you go to the hospital and you have a surgery, right? Just like you're having surgery, somebody who's in a crisis goes to an inpatient psychiatric unit for stabilization, right? And then maybe you get a cast after your surgery, right? Immobilizes the ankle, affects your ability to ambulate. It's just like partial hospitalization or PHP, right? That is profound impacts on life domains, and perhaps you're not going to school or you're not going to work. So the cast immobilizes your ability to be able to ambulate, or your symptoms immobilize you from being able to participate in your life domains. And then you have physical therapy, right? Physical therapy 2 or 3 times a week for an hour or two. You go to IOP 2 or 3 times for 3 hours a week. So, you know, that's helped me when I've kind of talked with families, is to put it in a perspective.
That's great.
Familiar with. Does that make sense?
Oh, I love that visual. I think you're spot on. And so, and also the message is you don't have to get or pay for surgery if really the physical therapy would get the job done, right? That surgery might be overkill in that moment.
Exactly. I mean, it's always about the least restrictive measure that you try to work with the client. Keep them at home, normal routine and activities. And so we don't wait until we have a heart attack. We do exercise, we change our diet, we reduce our stress levels, we use tools to manage that stress better. And maybe we take some kind of a medication. You know, we do preventative measures before we have the heart attack.
That's right.
The same thing in behavioral health.
Yeah. 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 And for the family too, it's quite a savings of resources, right? Because surgery is very costly, and being a family member of somebody who not too distant past needed behavioral health services, I was willing and prepared to invest whatever needed at that point. It's not true for everybody, but that was true for me. However, in the beginning, she didn't need all of that. So we started with the outpatient. When the interventions were not effective, then we increased our investment. And I think that in the long term, it really helps. The approach that you're suggesting is quite effective. We know it yields positive results, right? But it's also cost effective.
Right.
That what we do is the best use of resources, financial resources in the end. You being very intentional in delivering the service according to what the manifested need is, not the projected, not this is what everybody else does, this is the best course. This is gauged to the individual. And
yeah, I mean, we need to be data driven, right? I mean,
that's right.
And that's based on, what is the client experiencing and what intervention is going to manage that, reduce the symptoms, but provide them with the resilience to overcome adversity by providing them with skill set development. So agreed 100%. And, the other challenge when it comes to, we've been talking a little bit about residential environments. And in working with families, a lot of times, residential settings, there is an absolute need for residential as there is for inpatient. They're all essential points on the continuum of care. But the problem, and to your point, Beth, is that you can't consume all of the resources while in the residential environment. You need to preserve some of those resources for the maintenance or the continuing care or the reintegration back home. And if a residential, for example, consumes a lot of the PHP benefit or the IOP benefit, it doesn't leave anything left for the client to be able to reintegrate back into their normal lives. And that's been a challenge on occasion too when it comes to some of the other levels of care. You know, some of that's driven by managed care and you know, kind of restricting access to authorizations for care, but that's another discussion, right? So, but the point is it's about the continuum and using that continuum in benefit of the client.
Yeah, really good point. Wow. What else do you feel like is important for families particularly, but also our referral sources to understand about us, or our working relationship, our philosophy? Anything else either of you want to share?
Well, I can jump in here. You know, I guess when it comes to families in pre-contemplation of or considering their options, you know, it's a very complex landscape, right? Behavioral health, they don't know anything about the behavioral health landscape. And some clinicians have an idea, but they don't have clarity. And that's one of the things we've talked about today, right? So I think helping, you know, families should evaluate some different points, and that might be: is the program licensed? Are they accredited? You know, there's a lot of programs that provide services that don't even have an accreditation. A state license is one level, but that's typically going to be the minimum level of requirement. Accreditation requires a greater degree of transparency, and it's across international standards. It's not just the state. And it usually affects a broad spectrum of the domains of the facility. So I think accreditation is really important. I think if you ask them, now this will be difficult for the lay public, but from a clinician standpoint, if they're evaluating options, asking the treatment center, so tell me a little bit about your clinical orientation. Tell me about your clinical philosophy. If they can't give you a specific idea about how they approach treatment, then what does that treatment look like? Is it the clinician looking up on the internet real quick 10 minutes before a group and pulling a handout down off the internet? Or is it intentional? Is it cohesive? Is there a particular goal that they're trying to accomplish, or a skill set that they're trying to help the client to develop? So I think clinical fidelity and having intention behind what services you're delivering, having equine and ropes course and yoga, those are all great modalities, and they are sexy, right? I mean, they do kind of bring people to the side, but if it's used without intention and without fidelity to a treatment plan, then that's all it is, right? It's just sexy. It's not really used intentionally. I think from the lay public will struggle with that, but I think clinicians, if they can get clarity on how you work with clients from a clinical standpoint, that should give a degree of confidence to the clinician that, you know, you actually have a clinical program. What do they do about discharge planning? Discharge planning and continuing care planning is one of the areas that a lot of clients struggle with. And so how do they do that? Do they just look up on Psychology Today and say, gee, they're in their zip code, let's send them to Susie, you know? Or do they have people that they've established relationships with, especially if they're out of state. You know, that could be a challenge. So do they use their business development team that understands the lay of the land in a particular market that a client is returning to? Do they leverage that, that intelligence? So how do they do discharge planning? What about family? How do they incorporate family? And especially when it comes to young adults and adolescents, family is essential. If you don't have a family program that is integrated into treatment as an essential component of the delivery of care, then the client is going to struggle once they return home.
Yeah.
So, you know, I could go on and on and on.
Good.
You are singing our song.
You are. And you're saying, you know, one thing that you just said, I mean, you said so much, but one of the reasons that I think we're so in sync, you used the term continuing care. And I don't know a lot of people who use that term. We hear a lot of aftercare, right? From residential facilities. What are they doing for aftercare? Which to me makes it sound like this is care and everything else is after that. And continuing care is so important because the longer somebody stays engaged in some kind of community, formal, informal, it can look so many different ways, but that's really where sustained recovery happens. It's not like you said in the first 30 days where all the resources are exhausted. We need time, and that's continuing care.
Amen, sister.
And I love the language. We love that language. And that's what we were talking about at the beginning, just trying to be really intentional about what that is.
I couldn't agree with you more. I mean, and we've talked about this already, right? It's about language, the language that we use, and that, it's continuing care. It's not, as you point out, care after treatment, right? People don't have flights into health. That's not how medicine works, right? In medicine, there is maintenance that we have to do. There is continuing care. That's why you have the surgery and the cast and the physical therapy and, going forward.
Follow-ups.
All that stuff.
Wow.
So that's what makes it continuing care. It's continuing care. It's not aftercare.
This is why you are with us right now.
That's right. That's right. I think the last point to emphasize, and everything you just said in the last 5 minutes, is a coffee talk. The certification, the continuing care. I mean, these are, my wheels are turning, but the last thing, which also I think is a coffee talk, and it's important question for families or the individuals seeking services to ask is, how effective are you? And how do you know that you're effective? What do you do to study that? So, in outcomes is a big buzzword in behavioral health right now. But how do you do your outcomes? Well, you have a year and a half of data, which you've said, and I know you've already adjusted some things as far as your program delivery. And the same with us. We study outcomes with individuals, and we study outcomes overall to understand what the needs are, length of time required, for instance. Where does the most effective intervention happen, early on or middle or late? Those are important questions for families to ask, is how do you know that what you do actually is effective?
And, for an organization like us, we're a relatively small program, so it takes longer to build a data set. But we have done micro analysis and macro analysis. And so, we do that through, satisfaction surveys. So we actually quantify those satisfaction surveys, and we look at various small pieces of each domain to evaluate the satisfaction, because satisfaction is engagement, right? And so if the client is satisfied, there is a high degree of engagement. The higher the level of engagement, the better the outcome, right? So we evaluate each one of those pieces of each domain and quantify that and identify areas where we're not meeting or exceeding our benchmark, right? So we have set benchmarks. We have quantifiable data. We have set benchmarks. Where do we need to improve? We evaluate that improvement and make sure that we're getting the desired effect. So you do that through satisfaction surveys. We also use Basis 24, which is a peer-reviewed, well-studied symptom identification scale. And we do that at the time of admission. We do that at each treatment plan review, and that quantifies the degree of intensity of the behavioral health condition so that we can track that over time and plot that on a graph. And typically we'll see the reductions go down. It's not uncommon for us to see it to go up a little bit and for it to go down as treatment continues. And that's a good trend because they're seeing an improvement in their condition. They're becoming more vulnerable. They're establishing trust and rapport. They're doing deeper work. So you would expect some of those symptoms to go up. But then over a period of time, those skill sets that you're developing should take effect and continue to see the trendward down of the overall intensity of those symptoms, right? And so we try to look at that on an individual basis, providing guidance to the clinician in terms of the treatment goals and objectives and how effective those are. But if you look at it from a macro standpoint, so if you look at it over a 6-month period, you can determine whether or not you have statistically significant improvements in the domains evaluated through those symptom identification scales. And that's one thing that we have done is we've looked at that. And so we look at, okay, in this domain, we were right there at statistical significance. Over here, we had 3 domains. We were really statistically significant. What do we need to do over here, right? And so that's the process of continued program refinement, is looking at a micro and a macro standpoint of how efficacious the program is. You want to get to the point where you can publish that too. So.
Well, it's a lot of food for thought, and we're developing this this sheet, so to speak, or different materials that we can provide to families. One of which is questions to ask of providers, and this will be added. I mean, it's really just, we're at this place where we're creating things that can be resources for people, and that's great information.
Yeah, so we're trying to do that, being a young program, and, we're not a high volume machine like, some other providers in town. So we don't have the amount of data yet to be able to evaluate that effectively. But what we have evaluated, we try to, create a sense of change internally. And that's always a process of improvement as well, in trying to evaluate how. We also do, we do a family workshop each week, and we actually do surveys there, ask to make sure the content is relevant to their situation, what do they want education on. We also do clinical feedback forms each week, making sure that the clinical that we provide is relevant to them, that they're finding it effective. And so all those are measures of engagement and effectiveness. And we want to aspire to even be able to look at what is the therapeutic alliance between the client and the clinician, because therapeutic alliance is key and is directly correlated with outcome. So we could make this an entire coffee talk, right, about outcomes. The challenge with outcomes is infrastructure, right? Being able to have the tools that are reliable, synthesizing the data, making it actionable. That's the challenge. And do we have the infrastructure to do that? That's always a big challenge.
Well, let's bookmark it and make that a coffee talk, because I think we're really on to something with this. It's something that is not routine practice for, I'd say, a lot of behavioral health facilities. It is something that many recognize needs to be, and maybe are not sure how. And we're both sharing that we're also developing our own protocols. So we do not claim to have mastered it either, but are we measuring every week, every month, every quarter? Yeah, we are. And it's been super helpful to our program, our service delivery, all of it. So let's definitely talk about it. I know we've gotten a wealth of really good stuff that we can use here.